beneficial? Please.
So I'm going to focus my comments primarily on the effect of PEEP on right ventricular function. Obviously, as has been stated by other speakers, some patients will benefit from PEEP, some patients won't. But clearly, there is patients who the application of PEEP appropriately can and does improve right ventricular function. So I will discuss some of the literature that's been published primarily in the cardiac surgical literature, looking at the beneficial effects of recruitment and appropriately setting PEEP based on a decremental PEEP trial, and then present data after that we've accumulated in animal models and in obese patients to show that the approach to setting PEEP will determine the actual distribution of lung volume, and that we can end up having a very different pattern of opening the lung and thus improving the potential for right ventricular function based on the approach. So let me begin by my disclosure, although we will not be discussing any types of specific technology. So I think everybody in this audience is well aware, when we look at normal physiology, we have a nice relationship between ventilation and perfusion. Generally, when you look at the pressure volume curve of the respiratory system, it's such that the majority of ventilation goes to the dependent part of the lung, as the majority of perfusion goes to the dependent part of the lung. Less ventilation to the non-dependent, less perfusion, and as a result, we have a very nice matching of ventilation-perfusion ratios and minimal shunt and minimal dead space. Additionally, and sometimes we forget this, that when we look at the impact of lung volume on the development of pulmonary vascular resistance, that there's a U-shaped relationship. In other words, too little lung volume will result in an increase in pulmonary vascular resistance. Excessive lung volume will impact negatively pulmonary vascular resistance, and that there's a sweet spot in the middle, normal lung volume, that you have the best likelihood for minimizing that pulmonary vascular resistance. So the goal with setting PEEP would be to hit that sweet spot, the level where you've returned distribution of lung volume and lung volume itself as close as possible to what you'd expect it to be in a normal FRC circumstance. Well, atelectasis, pneumonia, ARDS, all the things we talk about that result in hypoxemic respiratory failure in some form or another, and obviously we can argue about the differences in the change in the pressure volume curve, but in general, it shifts the pressure volume curve to the right and downward as a result of elimination of tissue that can be adequately aerated. As a result of that elimination and that movement of the pressure volume curve, we shift where ventilation occurs. Ventilation does not occur primarily in the dependent part of the lung. That's where we see the loss of gas volume. It occurs in the middle and the upper zones where we have minimal perfusion. We affect the vasculature in the dependent part of the lung by causing it to constrict or collapse, and as a result, pulmonary vascular resistance dramatically increases in the majority of these patients that we are attempting to manage. So the focus of managing PEEP in these patients is try to reestablish as closely as possible overall normal lung volume. So there is an increasing amount of literature post-cardiac surgery indicating that the use of a recruitment maneuver and a decremental PEEP trial better establishes a PEEP level post-operatively that minimizes right ventricular dysfunction. This was the first study, and as you'll notice, randomized 24 patients. They did lung recruitment up to 45 centimeters of water, then a decremental PEEP trial, and compared that to the typical, at least in my institution, of 5 centimeters of water PEEP. ordered postoperatively on these patients, compared 5 to the open lung PEEP, which ended up to be 17, and in this first study, no negative impact on right ventricular function. Group with 5 of PEEP and the group with 17 of PEEP, when they looked at the right ventricular ejection fraction, no different. Exactly the same ejection fraction, in spite of that very dramatic difference in PEEP level between the two groups. In their second study, they looked more carefully at right ventricular function, basically the same overall methodology, recruitment, then decremental PEEP trial. Here ended up comparing 5 to 14 centimeters of water of PEEP level applied after lung recruitment, did transesophageal echocardiography at end inspiration and end expiration to determine the impedance to the outflow from the right ventricle. And as you'll notice here, the black solid column is with the low PEEP, and the hashed column is with the PEEP post-lung recruitment and decremental PEEP trial. And impedance to right ventricular function during inspiration, as you can see, was more effective with the low PEEP than it was with the high PEEP. Their argument was reestablishing lung volume, improve the ease with which blood flow would move through the pulmonary vasculature, and the impedance to right ventricular function was reduced, particularly during the higher pressures during inspiration. This other one, basically the same thing, recruitment, ended up looking again with echo at right ventricular function, and patients who were managed with the open lung approach had less impediment of right ventricular function. This is the most recent study that was just published a few months ago in the European Journal of Anesthesiology. 40 patients compared 6 centimeters of water PEEP to recruitment, and then 10 centimeters of water PEEP. As you'd expect, PO2 and compliance in the recruitment group increased, but look at the impact on cardiac index postoperatively. So what you see in the columns here is a control group is the group with the 6 centimeters of water PEEP. Here is the group that received the recruitment maneuver. Pre-op, right after surgery, and then after the establishment of the approach to ventilation, note that the cardiac index is improved, note that the right ventricular ejection fraction efficiency is improved, and that there's a more normalization of the right ventricle to left ventricle end diastolic volume ratio in the group that had been managed with lung recruitment and then the appropriate application of PEEP. So why might that be the case? Why would we see this type of change in distribution in effect on right ventricular function? This is data that we have impressed in an animal model of obesity. And I present this to show the impact of the approach to setting PEEP on the distribution of increased lung volume, depending upon whether you did a simple procedure of increasing PEEP versus recruitment and then determining PEEP by a decremental PEEP trial. I think it's important to note that in both of these applications, the end expiratory transpulmonary pressure was the same, as Danny Telmore talked about, ended up to be around plus 2 centimeters of water. PEEP levels, arguably the same, 1.5 centimeter water difference between the two, but if we look at oxygenation status, end expiratory lung volume change, there is a difference between the two that may not be accounted for that slight difference in overall PEEP level. If we look at the hemodynamic effects, pretty much similar, except a increase in pulmonary vascular resistance compared to baseline with the incremental PEEP approach, and a little bit higher shunt fraction, otherwise pretty much equivalent relationships between the two. We did CT scans on these animals, and here's where you see a bigger difference between the two approaches. And I would focus your attention on baseline data here, and then the incremental PEEP trial versus the decremental PEEP trial. And as you'll notice, the overall change in lung volume is greater with the recruitment followed by decremental PEEP trial. If you look at the amount of non-aerated tissue, it's much closer to baseline with the decremental PEEP trial as compared to the incremental PEEP trial, and very little increase in overall overdistension with the decremental PEEP trial. So this is obese patient. This is a markedly obese patient, body mass index of about 60. And you have an incremental and a decremental PEEP trial. The incremental PEEP trial done, the decremental PEEP trial immediately following that with recruitment. And as you'll notice, here in the blue is the amount of collapse. This is the amount of overdistension. Now, it's probably difficult to see from the back of the room, but this is at 25 centimeters of water PEEP. This is at 23 centimeters of water PEEP. This is at 19 centimeters of water PEEP. This is at 21 centimeters. This is 19. This is 17. Same amount of PEEP applied in the two circumstances. When we looked at the optimal PEEP level, again, we made sure it was equivalent to an end expiratory transpulmonary pressure of approximately 21, which was this level. Note the difference in the amount of collapse with the incremental PEEP trial at the same level of 23 centimeters of water compared to 23 centimeters of water after recruitment and a decremental PEEP trial. The issue here is that at the same PEEP level, depending upon how you achieved that PEEP level, you can end up with very different distributions of gas volume, very different levels of collapse, and different levels of overdistension. So we have now preliminary data on 8 patients, all markedly obese patients with severe hypoxemia, PF ratios when we start out less than 150. We can argue whether these were ARDS or not ARDS patients. The clinicians at the bedside felt they weren't ARDS. We could argue based on their presentation whether some would fit that criteria, but all had very severe hypoxemia. Note that as we look at the percent collapse, incremental versus decremental setting of PEEP, the same exact PEEP level, the same exact end expiratory transpulmonary pressure of 2 centimeters of water. Huge difference in the percentage of collapse when an incremental approach was used to set PEEP versus a decremental approach. Overdistension, the same thing. With the incremental approach, much more variability and much higher levels of overdistension than with the decremental PEEP trial. Obviously some overdistension, but not anywhere near the extent that we saw with the incremental PEEP trial. So I would expect, as we continue to look at this patient population and now have added echocardiography to the process, we'll be able to see whether that simple difference between the approach had a marked effect on the overall function of the right ventricle. So I would conclude that the effect of PEEP on right ventricular function is related to the approach to setting PEEP more than the actual PEEP level. Now, obviously, there's going to be patients who won't tolerate even modest increases in PEEP, but the average patient without baseline myocardial dysfunction can mostly tolerate a fair amount of PEEP, particularly if it's applied in a recruitment followed by decremental adjustment of PEEP. Better gas distribution and VQ matching with recruitment and decremental PEEP, lung volume and lung volume distribution more close to that nadir we saw in the pulmonary vascular resistance versus lung volume curve that I indicated before, if we do a recruitment followed by a decremental PEEP, then simply applying a specified PEEP level, whatever that PEEP level happens to be. Thank you.
Thank you, Robert. Any question? So, Can you tell us how do you usually recruit the lung and which higher pressure do you reach?
So we recruit the lung in pressure control ventilation, similar to the argument of using size in pressure control ventilation. We will begin at whatever peak level the patient is at, and then in stepwise manner increase peak 5 centimeters of water for 5 to 7 or 8 breaths, and then again and again until we get to 45 to 50 centimeters of water peak airway pressure. We leave the pressure there for 1 minute, and then we do the decremental peak trial. Now, doing the decremental peak trial, we switch back to volume ventilation because it's a lot easier. Every ventilator tells you the compliance when you go to volume ventilation. So we go downward in 2 centimeter steps until we can identify the best compliance peak, and then re-recruit the lung, and then set PEEP at the best compliance PEEP plus 2 centimeters of water.
Do you take also in account the transpulmonary pressure, because based on respiratory mechanism for the same higher pressure, the transpulmonary pressure can be very different from patient to patient?
So we've accumulated data on over 40 now markedly obese patients using this process. And what we found is that the PEEP level we choose by lung mechanics is equivalent to the PEEP level we would choose by setting the end expiratory transpulmonary pressure at 2 centimeters of water. It just comes out exactly that way. In this paper we had published that every patient, we titrated the PEEP level by both methods, with just looking at the esophageal pressure and then looking at the best compliance, and we came out with the exact same level of PEEP. So yes, we put the balloons in when we do studies, but if we're setting the PEEP just for clinical purposes, not always putting the balloon in, because we know we're very close, if not right on that positive 2 centimeters of water transpulmonary pressure.
No, the question here, just very short question. There is a question over there. It's a very short question. In the meanwhile, can we put the phone?
In the front.
Thank you for that. Your explanation of how you did the recruitment maneuver, I missed what you said